you, Suzanne, for the invite and the opportunity to present my research. So my background is originally in psychology, before moving through to mechanical engineering, where I did my PhD, looking at how you involve users in the design of healthcare technology. I then worked in the medical device industry in the UK for a little while, and then spent the last 5 to 6 years working in palliative care research and developing technology. So most of my work is based in the UK, but I also have partners across Europe, and we do some work with Sub-Saharan Africa as well, and hopefully soon in Indonesia. So I'm going to focus on my research and technology development in palliative care, but just want to highlight that I'm also keen to explore applications of technology outside advanced cancer, so away from palliative care as well. I'm keen to see where there might be scope to implement and explore technology, perhaps in earlier stages, such as during treatments. I'm going to give a little bit of background on the University of Leeds, very briefly, and then describe the place of palliative care and the place of technology. Then outline some research projects that I've undertaken and their findings, and then I'll summarise some of the key lessons I've learned from that research and some of my future plans as well. So just in terms of where I'm from, the University of Leeds, it's a big organisation with multiple national and international links. We have just over 33,000 students, around 8,000 staff, and we were awarded University of the Year in the UK in 2017, ranked in the top 100 World University rankings and top 10 for research power in the UK, and also have good ratings with student experience. But the environment I work in is more the Faculty of Medicine and Health at the University of Leeds. We have real strengths across cancer research, also palliative and supportive care. And the key themes for the Faculty of Medicine and Health include cancer, especially the psychosocial aspects, so psychological theory and understanding to support cancer patients, and also sociological as well. We also have a lot of research in data informatics, so big data, how you use data in healthcare, and also clinical trials as well. But there are also lots of other subject studies such as genetics, biomedicine, immunology, infections, so we have a lot of research going on. Most of my work takes place in the Institute of Health Sciences in the faculty, and there are multiple multidisciplinary groups within the institute. So I work across the UK and internationally, so I'm based at the St Gemma's on the right, St Gemma's academic unit of palliative care most of the time, but I also work closely with the Nuffield Centre for International Health and Development. So the team I spend most of my time with, the academic unit, we're a very mixed, diverse group. We're led by Professor Mike Bennett. He's the lead of the unit. He's a consultant in palliative medicine, specialising in pain management. But the team also has other specialisms and focus on questions around referrals to palliative care. I cover a lot of the technology, also neuropathic pain. We have a qualitative researcher and also statistics. So I just wanted to briefly cover palliative care, how it's defined. So the World Health Organization definition around an approach that improves the quality of life of patients and their families facing problems with life-threatening illness through the prevention of relief of suffering by means of early identification, ethical assessment and treatment of pain and other problems. In the UK, there's a real emphasis in palliative care research about discussions with patients and advanced care planning. So very early on, having palliative care involvement at least 12 months before death. Ideally, having discussions about where a patient wants to be cared for, where they'd like to die. That's the real emphasis in the UK about early conversations. And also the idea that palliative care isn't just there to support a good death. It can be delivered as far back as cancer treatments and starting to think about where there might be complex symptoms and the need for specialist input. So that's the sort of model in the UK. Palliative care is available to support multiple cancer and non-cancer conditions in the UK, several examples here across the different types. And again, common symptoms occur across all conditions such as pain, fatigue, with pain being the most common. In the UK, about a century ago, death was typically quite sudden, it was unexpected, unplanned, things like infections and accidents were the lead cause. And today that sudden death is less common, and that's the case across emerging sort of economies as well. And understanding the trajectories has been a real driver in research in the UK. And there's a guy, the researcher Scott Murray at Edinburgh has been really pushing this research field forward. And there are three really quite distinct trajectories that we have so far to look at people with progressive chronic illnesses. And the first is cancer at the top, where you can see a steady progression, usually with a clear drop and a terminal phase. There are others in the middle, so that represents things like respiratory and heart failure, where there's a trajectory with a gradual decline, punctuated by episodes of acute deterioration and some recovery, and then a sudden, unexpected death. And then the bottom one represents sort of frailty or people with dementia, so it might be a gradual decline that takes place over many years. And awareness of these types of trajectories from research is used to help clinicians plan care and think about the patient's potential needs in the future. So more generally in the UK, as I mentioned before, there's a move away from palliative care being perceived as relevant only in the final phase of life, replaced with the concept of the palliative care approach can be often increasingly alongside curative treatment to support people with chronic progressive illnesses. So that's a little context of palliative care, and hopefully over the coming days I'll have a chance to speak to the palliative care team about how the provision in the UK and compare that to Indonesia. But I wanted to focus today more on technology and how does that fit with palliative care. So I think technology creates an opportunity not to replace existing communication and interaction with health professionals, but a way of enhancing existing services, and that's certainly the ethos a lot of our work in the UK has had in terms of how we use technology. It comes in lots of different forms, so I thought I would start just by defining some of the big terms for those who are less familiar with technology research in healthcare. So we have e-health. That's a term that's just a broad term for healthcare practice supported by electronic processes. There's also m-health, so the use of mobile phones specifically. And then there are these three that are used interchangeably but have quite specific meanings. There's telecare, so that's remote care of, for example, elderly or physically less able people, providing reassurance and helping them to remain independent and live at home, such as wall sensors. We also have telemedicine, so that's where diagnosis and treatment can occur remotely, such as blood pressure monitoring. And then there's telehealth, so the provision of healthcare by means of telecommunications technology, so for example, Skype. So in terms of the place of technology in palliative care, there's a systematic review published in 2016 by Allsop outlining current developments, and they found 11 different types of technology being used across palliative care. And this is across the international literature, so for example, finding video, websites, telephone video conferencing being used. But they acknowledge that technology at the moment in palliative care is at really a very early stage of development. And also, one of the things that came out of the literature is the fact that at the moment the affordances of technology, so its full capabilities and what technology can do, isn't being realised as part of healthcare. There was an example in the British Medical Journal recently of a clinician using their mobile phone for WhatsApp and lots of complex meetings outside the hospital, but as soon as they then go to do their shift, they're using fax machines, they're using pagers, and there's a real mismatch at the moment about the technology use in personal lives and then how we can start to think about using that as part of the work we do and delivery in healthcare. So there's a bit of a divide at the moment. And I don't think that's the case just for palliative care, I think that's broadly across healthcare generally. So I've been carrying out research at this early stage of exploration in palliative care. Different approaches being explored, there's limited evidence. So I wanted to introduce my own research and how this can be broken down to address three broad questions. So the first, how do you design technology systems for palliative care? I'll talk through the process that we followed recently to develop a pain management system. Secondly, how do you map out the need and demand for technology in palliative care? So I'll talk about a little bit of our work in Sub-Saharan Africa. And then how do you evaluate data generated by technology systems in palliative care? And I'll talk about two studies. One was a coordination system for patients in palliative care, and another was a recent national survey that we did to look at when referrals are made into palliative care across the UK. So that first question, how do you design technology systems for palliative care? We've explored the approach of designing a technology system, but as I mentioned before, we always try to ensure that any technology we develop is embedded in a clinical problem. So we don't look for problems to address with technology, it's identifying the problem first and then thinking about how technology might fit in with that. So in terms of the clinical problem we were addressing, we're focusing on pain in advanced cancer, where moderate to severe pain is common, so around 65% of patients. Pain really affects the quality of life and has an adverse effect on caregivers. And we know that there are evidence-based clinical practice guidelines, but pain continues to be undertreated. Some of the barriers that we know from the literature at the patient level, there are sometimes there's a reluctance to complain about symptoms or a fear of pain. For health professionals, there's often or can be inadequate assessment of pain or reluctance to prescribe and monitor analgesia. And then at the health system level, there's ineffective communication of data on pain, preventing patient access to timely analgesia. So these are, particularly around the UK literature, fairly well established issues in pain management. So we thought that technology might provide a neutral platform for trying to introduce routine monitoring and assessment of pain for patients. So with limited research in the area and evidence at quite an early stage, we wanted to make sure that we adopted a rigorous process to development. And I've realised that this is quite not a very clear picture. So I can maybe just talk through what we're trying to do. So down the middle, essentially, if you imagine this is the technology system. So we started with some development work, moved through to some testing, and then we did some system refinement before we put the system into a clinical trial. So I'm just going to talk about the different stages and some of the findings. So early on, this is patients here, so we've had some early qualitative work with patients to understand their needs. Similarly with health professionals, we did some qualitative work. Then we did some user testing with patients and health professionals, and then we did a few refinements just before putting the system into a clinical trial. So we started right at the beginning with a literature review, looking at existing information communication technology systems for pain management in palliative care patients with cancer, and we found there were 24 articles, mostly across the US and Europe, although there was one from Japan describing different systems. And we found that most of the study designs were non-experimental. There were a few randomised, but most sort of observational studies or descriptions of existing systems. We also found that different stages of development were being described, but not across all the stages. So there were a couple of studies outlining the planning stage of systems, some looking at user needs, some talking about design, but not really covering all stages of any one system's design. And we found that pain was being captured as part of quality of life, so not really specifically looking at pain assessment. And those systems were unidirectional, so where you have an electronic system that captures information from a patient and then sends it to a health professional, but then the patient receives nothing back. So it's very much, here's a system to give the clinician information, but we're not thinking about maybe what information patients can receive from the system as well. So the literature review confirmed there were a few systems designed for pain management, so we wanted to start to design our own systems specifically to support pain management. We have a relationship with a commercial company at the university called XLab, and they have a platform where they can develop essentially questionnaire systems online, so that you can set up which questions you'd like to ask patients and what information you can fed back to them. And you can also link that information directly to health professionals. There's potential in terms of the system that we use to link that to existing clinical records. So if the patient reports pain, that can then go straight through to their clinical records. And the system's being used, I'm only going to talk about how we've used it for pain management, but the same system's being used in, for example, cancer treatments, to look at adverse events reported, where a patient might be at home having undergone chemotherapy, and then they can do routine online assessments that will help to flag up any pain or nausea or problems, and that information is sent straight to the health professionals. That's quite a dynamic platform, but I'll only talk about our use with pain management. So we carried out a feasibility study. Before working with advanced cancer patients, we first started with chronic pain patients, so staff and students from the University of Leeds. And we asked participants to complete twice daily pain assessments using the brief pain inventory over 2 days using a range of different modes. So they could access the system using PC or laptop, a smartphone, using SMS, or using a tablet. And it was quite a basic electronic version of the pain assessment that we used. Some of the findings from that 62% completed all assessments. Generally, it was reported as being quick and easy. The PC was preferred. In terms of assessing pain by SMS, because we were using a brief pain inventory, it was very burdensome. The first question would be sent, such as, how much pain have you had in the last 12 hours? The patient would text the response, that would go back, then they get the next question. So you can imagine that was quite a difficult process to do and quite burdensome, so that wasn't favoured. So we didn't progress with the SMS route. So we've done an online system that people can access using a PC or using their mobile phone if they have internet access. And overall, 68% felt that pain reporting was useful. It can improve recall, it can promote self-management, and also enhance communication. So we knew that the approach was feasible, and so we needed to engage with intended users to understand their needs to inform development. So we carried out some qualitative work using face-to-face interviews with 13 patients with advanced cancer, exploring their current pain experience and where technology might be able to support pain management. And 4 themes emerged from this work. So the first being, I'm trying to understand what is going on. So we found that for these patients, normality, or what their old normality used to be, had changed, and they were trying to adapt to the new situation. So as an example of a quote from that qualitative work, one patient reported, that's what I want, I just want normality, but the normality is gone. There's no normality anymore unless I'm on my own. But even then I look at the house and I think, God, if I wasn't ill, I'd have this decorated and all sorts done by now, and it's horrible. Because I know as soon as I do something, I'm going to be in agony. Another thing we found that pain is ever changing, it's quite difficult to control, and that pain fluctuates all the time, and the patients find that medication is like quite a key means of trying to control their pain. So as another example, an excerpt from one patient had medicines upstairs and medicines downstairs. So that if I get stuck on one level, at least I've got to get to the front. I've only got to get to the front room because it's on the bottom window. So if I'm upstairs, I only have to get to the bedroom because it's on the dressing table top in there. So I know I've not got very far to get my medicine. So that reliance on medicine as a means of managing their pain. We also found that I'm selective. Another thing that came out is I'm selective about who I tell about my pain. So we found that patients are quite selective in terms of who they have those discussions with about pain. And there was also an issue where patients didn't want to be a burden on their caregivers. So for example, one patient told us, yes, I tend to keep difficult things away from my wife because she doesn't cope with it very well. She always sees the dark side of things, and quite frankly, I don't find that very helpful. So that was trying to understand really where pain is affecting people's lives and the experience of patients. But we also looked around technology. We found that for some patients it was seen as something that could be part of their care, but it's something that's not used in healthcare yet. It was also quite peripheral, so patients tend to use technology to communicate with friends and family, but we've still got some way to go to introducing that into their care. And also for older patients, we found that there's a real a real focus on using technology for human contact rather than trying to replace that. So one patient said the fact that I use the phone, it's the human voice, it's being able to talk to a human voice knowing that I'm passing the message on the electronic way is to me a bit vague, because I'm never sure that it gets where it should be. We also spoke to health professionals in the design of the system, so we spoke to palliative care doctors, we spoke to nurses in both palliative care and the community, and we spoke to GPs, so general practitioners in primary care as well. And three key themes came from this work. So when we were talking about the possibility of using technology in palliative care, we found there were some uncertainties about integration of pain check, that's the pain management system, and changes to current practice. So, for example, people who don't normally bother you at all, they may actually feel confident in just doing this because it gives them a list of triggers suggesting and particularly for people who find it hard to put pain into words, some of them I actually think it will be quite useful. So there was some uncertainty about where alerts from these types of systems might go, and some uncertainty, but overall health professionals would see some benefit to the technology. In terms of the second one, appraisal of current practice, health professionals thought that interestingly, health professionals thought that they currently provide a very good level of pain assessment, and that actually if this system triggered issues with pain, that actually they just want to follow up. So this is an example. It takes a conscious effort to think of non-pharmaceutical measures such as positional one. So what we found in terms of the health professionals, they thought they were already assessing pain very well. That was their kind of way of doing it, and then we were saying, well, what about offering self-management advice and those types of things? And health professionals didn't feel as comfortable doing that, so the system might be one way of doing that. And the last thing that came out of this was that pain management is everybody's responsibility. So, for example, here, but some people want to be in a certain amount of pain, they don't want to be free. Because if they've got pain, they want to monitor it, they don't want to hide it, or they don't want to cover it all up, because then they won't know how they are. So we've done some user engagement, spoke to patients, tried to understand their perspective, also spoken to health professionals, and then from that we had an idea of this, the sort of structure of how a system might work. So we had pain check. So in terms of how this works, there'll be a demonstration of this system tomorrow, where you can actually use the system as a patient and as a health professional. So you have a patient at home who might be in pain. They send a structured assessment to the system, so they can do that by using their mobile or their PC. At that point, once they've submitted their pain information, they actually get some immediate feedback that gives them suggestions about different approaches they might try to take to manage their pain, such as having a bath, music, different types of approaches that people find helpful. But equally, that information is sent directly to a health professional, and in real time, if high levels of pain are reported, an email is automatically sent to a health professional. That could be, a consultant. In the study we're currently running, that's a nurse specialist who can then act on that information. And that's, yes, and then the health professional can feed back into the system and say what action they intend to take, and then the patient's informed. So it's that kind of complete loop. So we had a model of the system and a prototype, but then we wanted to test it before we used it in a trial, so just a little bit of improvement. So we wanted to assess the usability of the system for people, and also the fidelity, so how well the system captured data. And we used ThinkAloud interviews. So this isn't a commonly used method, but when you're developing a system, ThinkAloud is where you ask somebody to use a new system, and then you ask them to constantly speak as they're using it. And just have a constant stream of conversation. And you use that as a way of trying to understand where there might be errors. So they might be using the system and going through it, And then say, for example, oh, I'm finding this bit difficult to understand, or I don't know where this is, and that helps to highlight whether it's usability problems. So the four things that arose was this making sense of pain check for a health professional. So the health professional system where all the patient information is sent was very similar to dashboards they already use. So that made it very easy for them to use it straight away from the health professionals. There was also another thing around considering how pain check might be helpful. So health professionals felt it would be useful in clinical practice, but some felt it was maybe a bit basic. And then integration to clinical practice was some concern around where alerts would go and those types of things previously discussed. So just in terms of where we're at with the system at the moment, we have done that initial development, tested it and the usability, and now it's actually currently part of a trial. That system is one part of a complex intervention that we're trialing at the moment. So referrals are coming from oncology clinics initially. So I was talking about palliative care being delivered earlier and earlier in the UK. So we're actually picking up patients that report high levels of pain in oncology. But the eligibility is advanced and curable cancer, so they might be receiving cancer treatments with palliative intent. And then they're referred to community palliative care, so that's an earlier referral than normal as part of this trial. And they either have usual care, or they have this supported, it's sort of like an enhanced self-management package, where they have community palliative care and they're given an educational intervention, so some written materials for pain management, and given access to the pain check system. So we're just looking at that at the moment. We're just about to recruit our 160th patient. And then that trial will be completed, so we'll be able to start analysis on that. But we've been doing 6 and 12-week post-randomisation follow-up as well, in terms of understanding how that overall intervention has an impact on pain management. So that's the design. So in terms of designing the system, I was also thinking about approaches you might take, and approaches we've used before to map out where technology might be needed in palliative care. And I was going to talk briefly about my work in Sub-Saharan Africa. So in terms of that context, the clinical problem, there's the big issues around access to palliative care services. There's also increasing rates of cancer and non-communicable diseases. So there are needs to explore different approaches to longer-term contact with this particular group of patients. In terms of context in Sub-Saharan Africa, mHealth, so mobile phone health, using mobile phones in health is really promising. Mobile phone ownership is massive, it's really improving in Sub-Saharan Africa, so there's a potential way of capitalising on that. However, there's little rigorous evidence on mobile phone interventions, so we wanted to map out the current context before starting any work. So again, we started out with a literature review to understand what work has been completed. We found that of 1,175 met the inclusion criteria. We found some existing work across Nigeria, Uganda, Kenya and Malawi. And we found that existing health interventions and palliative care in that region have been developed. The use of palliative care treatment, at the guidance and coordination stage of provision. But the levels of detail about the development and structure of the interventions was very low. So with limited literature, we started to complete some piloting work. So we implemented an electronic application for recording and organising pharmaceutical records in palliative care. And people at the pharmacy, health professionals at the pharmacy could access this system on a tablet computer or using their mobile phone. And the application was, the idea was to streamline paper-based recording across multiple systems. And we looked at this at an urban site and a rural site, so hospitals in Uganda and then at Gombe as well. And we measured the completeness of data capture, so that entry of key patient variables and patient prescriptions that were recorded. We also looked at time efficiencies, so how long it took to retrieve patient records, and then we also looked at medicines, so the frequency of stockouts, and how that was changed by the system. Here's just an example of how the health professional dashboard looks. So at the top, quite simple, large icons you can use for entering information on patients and also on pharmacy. related information. And here's an example of the inventory that pharmacies would see. So the one at the top is soon to expire medications. These have a little bit longer left, so it's just trying to prioritise the workflow of pharmacists. So we mapped out a causal pathway, and this is something that doesn't typically happen in technology research in terms of thinking through actually what is the difference you want to try and make through implementing technology. So at the moment, the way it would currently work is that here you have patients with a new paper prescription that they take to the pharmacy, and then also paper-based notes are recorded, but we wanted to consolidate all that into one online system. Again, the prescription's reviewed, and there's paper-based patient notes of data being stored, but then again, we wanted to reduce that as well, because one of the big key things that's happening at the moment is that a lot of pharmacies have to do regulatory reports, routine monitoring, and stock monitoring. So that involves lots of compiling of paper-based records and all those types of things, so just trying to really speed that process up. And the patient experience as well, so the patient would arrive at a facility, and then they would arrive, and then the health facility would try to find their paper record. If they find it, great, they can inform the consultation on patient records. If they don't, the patient goes into clinic without any background. And it's those types of things that we're trying to reduce so that a patient can then go to the pharmacy. Here at the moment, they go to the pharmacy, the medicine might be out of stock, so then they go back and have to get a different prescription, whereas that wouldn't be the case with this new system. So the findings of the pilot were promising. We found improvements across all the different metrics we were looking at. So in terms of time efficiencies, time spent retrieving records dropped from 30 minutes to 5 minutes and 45 to 5. I guess the big drops are around preparing pharmacy reports. So at the moment, at baseline, we found that pharmacy reports were taking up to 2 weeks at some sites at the urban site, and that dropped to 1 day. Because it was all very simple to do reporting using the system. And also in terms of wastage of stock, it reduced from 3% at the urban hospice to 0.5%, but from the rural hospice from 58% to no waste, so real improvements. During piloting, it became evident that there was a lot of mobile phone use on the ground in the clinics, but that wasn't reported in the research literature. So we wanted to have a better idea of actually what is the current state. So we did a continent-wide survey to all facilities, asking them where mobile phones are currently being used in patient and family care and any barriers they thought there might be. So this is currently under review with BMC Palliative Care. So I'm aware that some of these images aren't very clear, so I'll provide the slides after if people want to look at them in more detail. This is an existing framework by the World Health Organization on mobile phone use in healthcare. It was originally developed for child and maternal health, but we adapted it for palliative care. So we put the palliative care pathway along the top, so starting with diagnosis, moving through to management, and then terminal care, and then bereavement care. And then down the side, there are all the different uses of mobile phones for patients and also for health professionals. And you can plot, for example, here, you may have, during the diagnosis stage, the use of client education, so that might be patient education interventions delivered by mobile phone. And you can use this framework to map where current work and literature is occurring. So in terms of what we found, the pink is where studies know mHealth was reported by the provider, or people didn't respond, but in terms of the responders, it's this yellow, this sort of lighter brown and the darker brown. So most that responded, there were very few here that didn't have any mHealth activity, and you can see that there are at least one to 5 types of mHealth being reported here, and then in the darker ones there are 5 or more mHealth applications, so quite a bit was actually going on across sub-Saharan Africa that we weren't picking up from the literature previously. We also looked at examples of different types. Again, I apologise, the text is very small, but in terms of data collection and reporting, for example, in Mauritania, we have both a patient visual analog scale and face scales on a tablet computer. The patient can either point somewhere on the line of the face on the scale. The clinician then records this by ticking the relevant box. So absolutely loads and loads of different mobile phone applications being used that we just weren't capturing in the literature review. We also identified priorities for health research. The primary one being people wanting to see how mobile phone applications could be used as part of patient care. And importantly, also identified a range of different barriers. So patients not having access to a phone is a big problem. Also mobile network access and unreliable networks and limited internet in some countries. Limited access to expertise and hardware. So key barriers that can really help us think through how we develop future health work. So that was sort of mapping out in terms of literature review, doing different surveys and exploring that. And then the last sort of question I wanted to talk about, the research linked to that, is how you evaluate data generated by technology systems for palliative care. So the first one I wanted to talk about was this idea of advanced care planning. So that's the early discussions with patients about what they might want their care to look like as an illness or disease progresses. And the evidence base for advanced care planning is that it can improve quality of life, it can reduce hospitalisations. However, these discussions, this is again a UK context, these discussions are not really happening. So the Department of Health suggested the implementation of these electronic palliative care coordination systems. In the UK, this is quite uncommon, where a high-level policy driver comes in and they suggest all these systems go in place, but then there's no evidence base to suggest actually this is a good thing. So we wanted to look at what was happening in our region, in Leeds, in the UK, when they were trying to use these coordination systems. So this is very clear, this is how it works. I'll sort of speak through this. So a GP or community practitioner can identify a patient as being end of life, so within 12 months of death. A very difficult prognosis to make, but that's what they're aiming for. And then they'll create one of these coordination records. The patient has to consent before the record's established, and then the EPACS, this electronic palliative care coordination system, is short to EPACS, is created, and it captures information about their palliative care diagnosis, their preferred place of death, where they'd like to be cared for, information such as out-of-hours care, and then that data should be shared across all health professionals involved in their care. So anybody with access to the electronic medical record should be able to see those preferences. So for example, if an ambulance shows up, or if a patient shows up at an emergency department, they should be able to see this information, and then it should inform their clinical decision making about how to manage the patient. For example, an ambulance showing up in the community, it may be that the patient would like to die at home instead of admitting them to hospital. There may be other approaches they could explore for the management of the patient. When we were undertaking the evaluation, we wanted to frame it in a theoretical framework, so we used this project review and objective evaluation that was developed by our informatics team at the university. It's quite interesting with frameworks. I was on Twitter the other day and somebody said frameworks are like toothbrushes. Everybody has one, but nobody wants to use anybody else's. And that's kind of the sort of, people can sometimes avoid using theoretical frameworks, but we're really keen to ground it in an existing one. And when you develop a system, you initially start at this bottom point, looking at technical aspects, then the usability, and then the clinical processes, so documenting how that happens. This is a very, very difficult part, and we still haven't reached this with EPACS in terms of linking electronic systems to the changes in patient outcomes. That's quite a difficult part to get to. So what we found, this system had been in place for a couple of years across Leeds. It had Department of Health backing, but interestingly, only 26% of eligible patients actually had a record in place, which was very, very low and quite a surprise to us. And in terms of how that's working, the EPACS record itself was opened 31 days before death, a median time of 31 days. There's a lot of variation in that. So for a system that's supposed to be supporting the last 12 months of life, this was quite an eye-opener. And also, information that should be captured by EPACS, this electronic coordination record, were already being entered to a medical record. So there's an issue here. We don't really know what the causation is, whether EPACS is basically just capturing where good practice is happening already, or whether having this record is prompting people to start entering additional information that they wouldn't otherwise. We don't really understand that process at the moment, so we have a grant application that's in the final stages, that will hopefully help us understand how the system's working a little more. I should explain that the size of the dots are related to the number of patients or the number of records that we have in each of those different stages that explain those data. The actual place of death was recorded 1 day after death, so -1 occupation death. Interestingly, sometimes the EPACs record was as well. So we have instances where this system's being used in practice where a patient should have had one of these records in place and didn't. So it might be that once the patient's died, they're cleaning up the electronic medical record, open up an EPAC and say, okay, that's done now, but then it's recorded after death. So there's quite a lot of weird, interesting sort of human interaction that's going on with these systems. And then one final study I wanted to talk about using routine data is this national survey that we've just completed. So we've got a draft manuscript, so this is pre-publication, but we're writing this up very, very soon. So we want to understand when referrals are being made to, we call in the UK specialist palliative care, so that's hospice care. I know that that's not widespread in Indonesia at the moment, but this is the situation in the UK. A lot of specialist palliative provision, so you have trained medical professionals in palliative care, both palliative care consultants and nurses are based on hospices with a range of other supporting multidisciplinary teams, such as physiotherapists, dietitians, there at the hospices. And we wanted to understand when referrals are coming into those services, because there are a lot of small sample studies, but no large national research that's been done on this yet, so we wanted to create a benchmark. So we sent out an invitation to hospices to take part and a few reminder emails. In total, we sent it out to about 200. We had about a third of all UK hospices respond, so we had 64 participants, or 64 sites participating. And we had two sets of, two ways hospices were reporting data. So we asked for information on patients, so we asked for their date of birth, their diagnosis, their date of death, and also their ethnicity. And that information was sent via a secure portal we had at the university for patient information, and then to the research team. We also asked for some information on the organisation, such as how many palliative care doctors they have, how many nurses they have, how many annual referrals they have, that type of information, and then that came to us via email. We also looked at some of the rural-urban index of the different postcodes, but we haven't used that in the analysis. And what we also did at this point as well is create benchmarking reports. So we had our own analysis that we wanted to do, but we sent to each of the participating hospices. I'll show you an example towards the end. We sent how the sort of median time from referral through to death for that particular site, how they performed, and then matched that or compared that to other regional hospices, so other hospices in their region, and then also nationally, how they compared to national figures. This is quite an early stage, so we asked for some feedback on the benchmarking, but I'll show you what that looks like once I've told you the findings for the analysis. So in total, we had 42,372 patients included in the analysis. We had to do some data cleaning, particularly around ethnicity. There were multiple vocabularies used for ethnicity data. So we aligned that to UK Office of National Statistics ethnicity categories, so that's national categories that we used. And also multiple coding systems were used, so we aligned it to those major cancer and non-cancer groups that I showed a little bit earlier on. So in terms of the patient level findings, what did we find? Well, we wanted to plot against this idea of the last 12 months of life, where referrals are being made to specialist level palliative care. So this isn't generalist, it's specialist. Quite surprisingly, in the whole of the, well, I said the whole of the UK, a third of hospices across the UK, the median time for referral to death is actually happening 48 days, that's just over 7 weeks. So although there's a massive policy drive for this early referral to palliative care, actually what we find is that hospice is still essentially providing quite a late stage end of life care service. In terms of age, we wanted to see what was happening, so we broke down the different age groups. So we looked at those under 50. Referrals are occurring 78 days before death, so that's quite a long time for that group. and there are about 2,000 patients in that particular group. Interestingly though, as you get older, referrals are happening later. So for those aged 50 to 74, it was 59 days, and there were 20,000 patients in that group. And then lastly, those aged 75 or over, referrals were happening 39 days, so just over a month before death. In terms of ethnicity, we're finding that those with ethnic group of white, so this is the majority of patients, so about 31,000 patients in here, it was 53 days. Then interestingly, we found that patients of Asian or Asian British ethnic group were 69 days, and then Black, African, Caribbean, Black British was 73 days. There were only 500 patients in both of these groups, and it contradicts the inequity that we normally find in palliative care in the UK, that actually those from Black minority ethnic groups are disadvantaged when it comes to access to palliative care. Those with other, so this is kind of Arab or ethnic groups who don't fit into the other three, was 35 days. But this is the sort of bit that raises doubt in terms of how much we can draw from these conclusions. There were 9,000 patients in that group, so missing or not recorded. We don't know obviously where those patients fall in terms of other groups, so we don't draw too much on these findings. But it might be that if those 9,000 patients are spread across these groups, we might lose that potentially, so we're not really sure of that at the moment. But that's one of the caveats of routine data. We also looked across cancer and non-cancer. So cancer patients were referred, or the median time from referral through to death was 53 days before death for cancer patients. Non-cancer patients was 27 days, so that's nearly half the duration of time. So non-cancer patients really having much shorter time in palliative care. In terms of timing of referrals, we looked at the likelihood of early or late referrals. So early referral were classed as referrals occurring 4 weeks or more before death. And then we compared conditions to lung cancer, because that was used as a reference group, because that was the largest group of patients. So cancer is significantly more likely to receive early referrals, included those with soft and connective tissues, brain, breast, colorectal and male genital reproductive organs. Those significantly more likely to receive late referrals included liver cancer and unknown other cancers. This is a group where diagnosis isn't necessarily clear, or you have a generic term like malignant tumour of unknown origin. So quite an unclear group of patients. So we're still comparing to lung cancer being the largest number of patients. Then we start to look at non-cancer conditions. Interestingly, no non-cancer condition was significantly more likely to have an early referral compared to lung cancer. But those significantly more likely to have late referrals included lung, kidney failure, neurological liver failure, and other non-cancer. Interestingly, stroke and dementia patients were 4 to 5 times more likely to have a late referral, so we can really count some disadvantaged groups to target future efforts. In terms of the organisational data, we grouped the different areas of the UK by high-level NHS England regional team labels. We only have 3 sites from Scotland take part and 2 from Wales, so we don't draw too much from that information. But in terms of North of England, we have 29 sites, and we found a median time of 35 days from referral to death. And that contrasts with the Midlands and East of England at 55, and South of England at 49 to 55 days. So we started to draw this idea of a north-south divide in terms of what's happening. We're not quite sure of the reasons, but these high-level patterns are quite interesting as a starting point. And we also explored case mix, so the percentage. We calculated this by understanding the percentage of non-cancer patients as a proportion of all patients at each site, and then we aggregated that at the regional level. So we found around 10% had non-cancer in Wales and Scotland. In the north of England, it was around 15%, and then it increases Midlands and the East to 70%, south of England at 21%, and then London had the highest at 30%. It's worth noting that actually the breakdown of cancer to non-cancer at best, probably all conditions in the UK, about 30% cancer, 70% non-cancer, but that is not reflected in terms of what specialist palliative care services are handling at the hospitals. So there's a real issue with access so palliative care for non-cancer conditions. We also looked at variation in terms of capacity. Overall, there's about a 1 to 2 ratio of about 4 full-time equivalents of palliative care doctors to 8 nursing community teams. But again, that varies, not so much for the doctors, but again, in the north of England, we're finding this, that over half of all hospices didn't have a community team. Again, that might be explained by the different models of delivery, but that was quite a surprise as well. So just some high-level things that we're finding from this routine data, this national survey. As you get older, you tend to get less palliative care. Non-cancer conditions are receiving half the number of days compared to cancer, and there's wide variation by condition for late referrals. In terms of the organisational level, we're seeing this north-south divide. There's widespread variation in case mix, and there are issues around staff capacity, particularly around nursing teams. Just some limitations from that type of work. We had around a third of all hospitals to take part, so that's great. It's quite a large, regionally representative survey, but it was only a third, so we might need to think about how we can include more hospitals next time. Missing data, that's a big problem for the ethnicity. You know, we're limited in terms of how much we can draw firm conclusions from the ethnicity data. In terms of quality of care, routine data is fantastic and it's really helpful to look at high-level trends, but what we don't know is the quality of care that occurs after referral. We don't know how many contacts they had with the palliative care service, so we can't really say anything about the quality of care that was delivered. And then we were using retrospective data and routine data, so it comes with its caveats. It's likely that there were some errors in coding and issues with some of the data that we were using. This is just an example of the benchmarking. This is performance here. You can see if this was your site, if you had a hospice, your performance is marked in red. In the yellow are other hospices in the region, and then in the grey, that shows all the participating hospices not in your region. And then we've also broken down for each hospice by age group, the median times for hospice versus national data, and then also for cancer, non-cancer versus their own data versus national data. We're exploring this at the moment. We're asking hospitals how we can improve this information, but this might be something we take forward year on year just for hospitals to assess their own performance. So I just wanted to answer some of the questions I first started with. So how do you design technology systems for palliative care? From the work I've completed, approach using technology should always be built from a clear clinical problem. It should focus on enhancing, not replacing existing communication between users. User involvement, so patients, caregivers, health professionals, their involvement is absolutely crucial, should guide development from the start, and that mapping out intended impact, consequences, changes from technology is really important to understand its impact on delivery of care, and that we can document stages of development throughout the whole system development process. In terms of how do you map out the need and demand for palliative care, well, understand the existing literature, you can survey current practice, research literature wasn't an accurate reflection of what was going on the ground in sub-Saharan Africa work, and then there isn't always a need to reinvent systems. You can explore where similar systems exist and adapt. In mobile phone health, there's this thing called a landscape review, where you can map out and chart all the different mobile applications that are being developed and think about which might match your needs. And then how do you evaluate data generated by technology systems in palliative care? Well, you need to understand the caveats, such as the national survey issues around missing data, ethnicity, draw on existing evaluation frameworks, and then working with decision makers to ensure pathways to impact. We completed our national survey with Hospice UK, which is a national charity that supports hospice practice across the UK, so our findings can directly inform what they do and the different practice they encourage hospices to do, so that link to policymakers is really important. Just to flag up some future research, so for the range of projects undertaken, some common themes keep coming up. So there's a need to really understand where systems add value for patients, so this unidirectional flow that I spoke about, in terms of health professionals asking patients for lots of information, and then not really thinking about what information patients can get from systems and how we can use that. That's an area I'm really keen to develop in the future. We also need to gain a better understanding of the interaction with systems. So this is a comment really on the current evaluation of systems. So at the moment, you tend to find a lot of systems focus, a lot of the evaluation focuses on the technology and the outcomes for the different stages. And a lot of people haven't really started to explore this idea of interaction with systems, what's going to encourage your patients to engage with the system, what's going to encourage your health professional to use the system. So I'm going to hopefully develop evaluation frameworks that capture all of this to enable a fuller evaluation. One other thing, developing suitable evaluation. With technology development at the moment, particularly commercial companies, you develop technology, you find a problem, you fix it, you find a problem, you fix it. Something like Google, they do user testing all the time in the background, and you wouldn't even know. They'll change something and then see how it affects user behaviour. That isn't how it happens in research at the moment. You develop a system and then you put it in a clinical trial, and it's in a trial for 3 years, and then you carry on development. That's quite limited. So just trying to find maybe new ways of carrying out evaluation with digital technology. I also just wanted to point out at this point, I've just moved to a new position at the university. I've just had a fellowship awarded for 5 years, focusing on technology development in cancer care. So the next few years I'll be really busy trying to develop grant applications, so really keen to explore areas of collaboration, not only in palliative care, but also moving, as I mentioned before, perhaps the earlier stages of cancer through treatment, those types of things. And thank you.